One of the hardest parts of my job is when a patient comes in for a confirmation of pregnancy and I'm doing an ultrasound. And usually the parents are excited, sometimes trying to sneak a picture of the ultrasound machine. And there's usually a lot of anxiety and a lot of excitement in the moment. And I put the ultrasound probe on the patient's belly, or if it's a transvaginal ultrasound, and I'm looking at the pregnancy and I see something where there's supposed to be a heartbeat and there isn't. And I get this sunken feeling in my chest, and I look over to the parents, and I usually try to find the words to explain to them what's happening. And as a way that I can express what is happening while being there for them. And honestly, I usually can't find the words. I usually look over to them, they see the look on my face, and they ask, "What's wrong?" And the only thing I can usually say to them is, "I am so sorry." And there's usually a moment there where they realize something is wrong, and we have this conversation. I'm making this video because I have so many patients that unfortunately, because we have a very high obstetrical practice that we deal with this very commonly, and it is such a strongly emotionally filled situation that although I spend the time going through this with them, I feel like I wanted to make a resource for people when they go home, they emotionally process and they're ready to receive the information and have a place to get it. So, today, what we're clearly talking about is something called a missed miscarriage or a missed abortion or a silent miscarriage. You may hear all of those terminologies to talk about what we're talking about today. There's other kinds of miscarriages which are incomplete or complete, but usually there's symptoms that are like bleeding, cramping that happen before that that usually trigger people to come in. In this situation, usually patients feel pregnant, like there's nothing wrong, and they come in expecting to hear good news and unfortunately hear bad news. The main purpose of this video is going to be to talk about what the next steps are and the treatment options. So, usually after that moment, patients respond in one of a few ways. Sometimes people get very logical and they talk to me like, what is the next step? What is happening? Where do we go from here? And like a coping mechanism, I'm trying to figure out basically shove the emotions in and move forward. And when that happens, a lot of times later, it emotionally hits them. Shock is very common. A lot of times, denial is a very common emotion that comes up. So I try to explain to them what's happening. And one of the most common questions I get asked is, "Are you sure?" And my short answer is yes. If I'm telling you this information, I'm sure. I'll make another video talking about how we actually diagnose this or how we date pregnancies, all that in another video. But when this information is given, we better be sure. And the criteria for calling something a miscarriage is very strict. And it's strict because the worst thing we can do is tell you something's wrong when it isn't. So going from there, we usually try to figure out what the next step is. There's three options for treatment, and I'm going to go through the three of them. The first is expectant management, and it's exactly what it sounds like. You do absolutely nothing. And just to give some context, 25% of patients miscarry. This is unfortunately unbelievably common, and 80% of people will spontaneously pass a pregnancy in 8 weeks. Usually at this point in time, like this option is reserved for people that mostly just don't want any interventions, number one. And number two, if they haven't emotionally and logically come to terms with what's happening. The worst thing I can do as a doctor is remove a pregnancy that's not viable while the patient thinks I'm taking a perfectly fine pregnancy out of them. So I do not do a procedure. I do not give people medication until they absolutely understand what's happening. Usually people also ask me and why this happened, especially if they're not fully understanding like what's happening. And I explain to people that, hey, if 1 in 4 pregnancies end in miscarriage, and by the way, it's 15 to 25% at 6 weeks, it goes down to a little under 5% at 8 weeks and 0.5% at 12 weeks. Is as you go along, it goes down and usually stays about 0.5% for the rest of the pregnancy after 12 weeks. But this happens most of the time, more than 50%, especially when it's early, is due to genetic causes. So if you have an egg and a sperm and they meet each other, that egg and sperm need to be genetically normal. And the combination of when they come together through a process called meiosis, that combination also has to be normal. And if you think about all that needs to happen for that to come together, it's amazing how many pregnancies actually turn out okay if you think about it, if you do the math. And the way I explain it is imagine you have a computer. If you had a defect in the computer, so like, oh, for example, people know what Down syndrome is, most people do, where you have an extra third chromosome of the 21st chromosome. Those babies that are born with Down syndrome, there's a huge range of symptoms, but there's usually some sort of limitations, and the limitations vary. If you had such a big problem that it couldn't even be formed, like past 6, 7, 8 weeks, there had to be such a big defect in the genetic material that it wouldn't start. Like if you had a computer and you had an issue in the startup sequence in the computer, it wouldn't happen. And now also because we have so much information on how, like, I have patients come to my office or call 4 weeks saying, hey, I have a positive pregnancy test. Your grandmother would not even have known she's pregnant. And unfortunately, the downside to that information is that there's a lot more people mourning losses that their grandmother wouldn't even know it existed. And that pain is real and it hurts. So most of the time it's a genetic cause, at least this early on. And it has nothing to do with the pregnant person or the father of the baby. It's because it happens and unfortunately it's normal and nature's not always the kindest. So going back to expected management, that is the first option. The second option is medical. And there's two medical options. One is called mifepristone and misoprostol. It's a combination option of those two medications. And that has a 94 percent success rate. Patients that take that combination pass the pregnancy in 3 days. The next option is just the misoprostol alone, and it's 70% in 3 days. So the main question I get from patients is why do people just do the misoprostol alone? And the reason is, for example, where I practice, we don't have the access to the mifepristone. They make it very, very difficult to get your hands on that medication because a lot of people use that medication for abortions. So there's a bunch of legal issues that unfortunately are limiting people's access to care. So in our practice, we don't have the ability to prescribe mifepristone. The third option is a DNC, which is a procedure. And the procedure, obviously, the advantage is it's done quicker and faster. The downside is your body is undergoing a procedure. And anytime you do a procedure in the uterus, there's risk of damaging stuff in the uterus. That risk is unbelievably low. They used to be done with like a scraping tool. Now we use more of a suction device, but with the scraping, there is a risk that you can damage the lining of the uterus. That can still happen, but it's very low. Because we don't scrape like we used to, there's always a risk, by the way, with any of these options that not everything passes. And on the other side, the risk of like expected management, the first option I gave, the longer something's there that shouldn't be there, there's at some point an increased risk of infection, especially after 4 weeks, that risk starts to increase. So usually at this point, when I explain this to patients, the next question is, Doc, what's the best option? And there's no right option here. The question is, what's best for you? We kind of talked about the expected management side. Most of my patients now, they tend to choose the procedure just because of where I practice and just for whatever reason, patients seem to prefer knowing that they just say, I don't want this inside me. I want everything out. And they're scared to bleed at home. So for right now in our practice pattern, that seems to be the dominant method that people choose. But where I practiced previously, a lot of people preferred the pill option because for them, they felt that the passage at home helped them mourn the loss of their pregnancy, and they felt it was more natural. Again, there's no right option here. I'm just trying to present them in the best way possible for you to make a decision for yourself. The risk to the pills, specifically the misoprostol, is there's a risk of fever. They can get some like GI upset. You can take the pills either like buccally, kind of in your cheek, or you can take it vaginally. I usually don't like people to swallow the pills because you can get more stomach pain. But there's some risk to that, but generally it's decently tolerated, but you have to expect to bleed because bleeding is the biggest risk at home. Again, talk to your doctor, whoever you're seeing about this, because the risks kind of change also on how pregnant you are. Dealing with a 6-week loss is very different than a 12-week loss. So they may make specific recommendations depending on your cause. Also, if this happened a few times, the advantage of doing the procedure is you can actually send the products of conception to a lab so they can test to see why that happened. So sometimes they're able to figure out, hey, there's this genetic issue, or a lot of times they come back inconclusive. Another question I get asked a lot is, okay, I had a miscarriage. What is my chance of getting pregnant again? Can I get pregnant again? And the short answer is yes. So we consider a recurrent pregnancy loss to be 3 losses in a row, but we usually do a workup after the second loss. So just some data, I'll put up a chart here, but after 3 losses, there's almost a 70% chance that you'll be able to have a successful pregnancy. And after 6, it's almost 60%. And I explain that to people just not to kind of make it all peachy and rosy, saying everything's okay, but to give them some actual data showing, hey, your chance moving forward is still decently high. There's other parts of this workup. I can make another video on recurrent pregnancy losses in the future, but there is other workups that you do when you have at least 2 losses in a row to make sure there's no other issues like a genetic stuff in the family or an autoimmune issue. What I kind of explained earlier, as a doctor, this is one of the hardest parts of my job. It hits me very emotionally, if I'm going to be completely honest. And what gets me through this is some of my most amazing happy moments in obstetrics specifically is when I go through this with the patient and then they get pregnant again and I'm able to walk them through the pregnancy process and deliver their baby. And knowing how much they were hurting and yearning for a family and being able to hand them their child and see their baby for the first time, knowing that's an option is what really personally gets me through these hard times. And it's hard to see that when you're going through that, but on my end, because I do this so often for so many people, I see what happens for lots of people over a lot of things. And again, everyone's situation is different. I'm just trying to give you some hope on what I see, on what actually happens without trying to belittle what you're going through because you're allowed to grieve, but there's hope. I can't promise outcomes, but if you look at the odds, it's in your favor. And however, or whatever your choices are after this that you're going through, we're going to get you through this and try to find the best future outcome for you. In closing, I just want to say again, I'm so sorry for what you're going through. You're going to get through this. We're going to help you through this. And I, again, would encourage you to reach out to people who you love and care about. And I think you'll be shocked to hear they may tell you a story of what they went through or someone they knew that they went through. And I think the harder the emotion, the sadder, the more extreme the emotion, the more universal it is. Because when you're going through this, a lot of people, again, go, why me? Why me? And they're shocked to hear about all the people around them that went through it. At least that's what I see in my practice. We're going to get you through this. If you have any questions, please leave them below. And I really hope you found this helpful and share this to whoever you think might benefit from seeing this video.